Well, welcome to GC Orthodontics Exchange podcast. My name is Michael Wilgus. I'm the regional manager for the West for GC Orthodontics. And today we have, again, the honor and pleasure to speaking with Dr. Bryn Cooper, orthodontist from Houston, Texas. If you didn't catch the last episode as a listener, I encourage you to go back and do that. It was a pretty awesome discussion that we had. You got to hear all about her journey into orthodontics up to where she is now, as well as sort of this internal evolution that went along with it. So, Dr. Cooper, for those that didn't get to hear the last episode, maybe just briefly again introduce yourself to our listeners.
Sure. I'm Dr. Bryn Cooper, and I am an orthodontist in Houston, Texas, with 2 locations. And I've been out now for almost 12 years, as we clarified on the last podcast. And it's been fun. It's been a journey to own my own practice and have different experiences getting there. So, yeah.
Awesome. Thank you. So, I think I mentioned too in our previous discussion, really the first time I got to meet you, you facilitated an educational session for our team around indirect bonding. And so today, what I wanted to do is really kind of take a look at digital orthodontics. And by that, I'm referring to indirect bonding and aligner specifically,
Yeah.
and where they kind of overlap from a clinical and a business standpoint in modern practices today. So, looking forward to you giving us your insights. I know that you use digital orthodontics in your practice, but with that, maybe let's go back to sort of the beginning of that introduction into digital orthodontics.
Yeah.
Where did that happen for you along the way?
So, digital orthodontics, I actually, when I opened my private practice, tried Insignia and did about a dozen cases there. Um, and my grandfather was an orthodontist, and he had been a beta tester for 3M in like the 70s and 80s.
Interesting.
And so one of my goals when I was in my own practice was to be able to be a beta tester for companies. I just thought it was cool. I mean, in all honesty, I just wanted to use the newest stuff and be one of the people that was like, yes, this thing is amazing. These parts of it are good and that part is trash, right? And so I really thought that digital orthodontics was the future. I opened my private practice plasterless and paperless, and this was 12 years ago. I had the first Vita, EnvisionTech Vita from Germany, was shipped to my practice. And it still works today. And now you can get printers for way less money that print the same quality. Yeah. And there are other people on the scene. But like this was before the other competitors even existed. So, I knew that because alginate and stone had the shrinkage component to those materials, that you could get a much more accurate model 3D printing. And I just thought that was so important because the accuracy was better. And so that was where I started my journey, is looking at, are these materials actually going to produce a better product for my patient? Or is it just technology for the sake of technology?
Sure.
So, indirect bonding jigs have had a huge evolution, and I knew I wanted to indirect bond because I had direct bonded and indirect bonded multiple cases throughout residency and throughout my contractorship. And so I knew indirect bonding was a great way to get really accurate bracket placement compared to what I could do in the mouth, as long as your techniques in the lab were done correctly. Because if your technique, there were a couple where I was training a new lab person, and those indirect bondings looked like a drunk person put the brackets on. And so then you'd have to redo it by hand, and that was always frustrating.
Sure.
But I have tried Sure Smile jigs. I have done Insignia jigs. I have done make my own jigs in my own lab. I have done incognito bracket jigs. I have done in-brace bracket jigs, and now I've used Dibs and GC Ortho jigs. So I've used at least 7 types of
Yeah,
tests.
no, that's awesome. So I want to go back. You mentioned something a second ago. In residency, you were
Mhm,
doing direct and indirect bonding. So
mhm,
it sounds like you had an introduction into indirect bonding there. And I have a
mhm.
confession to make that you don't know about me, but I worked for Invisalign for a while, back when it was the only aligner out there.
Yep,
I'm imagining that you got some exposure to aligners in residency
I
too.
did.
Okay. So I know from my days at Align, one of the biggest challenges that we faced was this mental paradigm shift in treatment planning,
Yep,
where we were taking and trying to get doctors to think prospectively using software with the end in mind, and then going backwards to make sure that all the movements were predictable and realistic
yep,
based on the software, as opposed to direct bonding where you know where you want to go, you put the brackets on, you put the wires in, but inevitably you're reacting to maybe movements that you didn't want to happen just through the nature of the mechanics,
right,
right? So there's two very different clinical sort of paradigms to deal with there.
right.
How did you were learning both these at the same time? Like how did that feel, and did you naturally just kind of gravitate towards digital at that point in your residency, or were you still kind of on the fence?
I goodness. I did believe that digital was where we were going. I could see that very clearly as in my late 20s and 30s, I was like, we're going towards custom treatments. My my thesis was actually done on the genetics of the lower jaw. And I was one of the first that collected saliva and did um, replication of mRNA from that. And Dr. Barents was very kind in saying this a couple years to me. He goes, "Your paper was the flashing warning sign that here it comes. Unique treatment is coming." He was like, "That was your message to the orthodontic community, Bryn." And oh, it just got me. I was like, "Oh, yes, I did believe that." Like and so I was one of those people that I was sitting there looking at it. I was like, "We're going to have custom treatments. We're going to have um unique treatments." And I actually thought, I think we're going to get there. We're going to know how people are going to grow too. Like, we're going to get to the point where we know who's going to outgrow their orthodontic treatment as a teenager and need surgery and who's not based on their genetics. I think we actually probably could do it now. It just hasn't become the most important thing.
Sure.
We're still trying to figure out the genetics of cancer and things like that, right? So, those projects are going to take precedence as far as the grants. Um, but it's coming. And so I don't know if I would have called it digital orthodontics at the time. I would have called it custom treatment
Mm,
at the time. Custom treatment is coming. And I think that it is important now that we have the tools to give people such individualized, customized treatment that we recognize that the level of care can be so much higher than it could have been even 10 years ago.
sure.
Um, and so the thing with aligners, and I love some of the uses for aligners, detailing in aligners,
Mm,
love it, right? Open bites in aligners, love it. There are some things in aligners that I love to treat in aligners. Um, I still struggle in my aligner setups to mentally calculate what I need to overcompensate
mm,
for each patient because it changes. I know we have the studies that show like 30% rotation is lost on canines, da 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 da. But I have not found that then building in 30% overcompensation on every canine gives me the result I desire.
sure.
And so when you're looking at cases where you've done three sets of aligners and you still have a premolar that's up high and you've put two different shaped attachments on there, I use digital monitoring with AI built in. And so they're taking photos from home and I'm watching them not progress to the next liner, not progress to the next liner, not pro- okay. Then I tell I tell them, okay, go on this next one. And we send the message. They get through 3 sets of multiple aligners. And I'm like, I don't know what else to build into this plan
Right.
to make this happen for this patient, right? But when I digitally plan my braces, whether it be metal and now I've gotten into some ceramic brackets, um, when I program that simulation, 90% of the time, the teeth land in that position because there have been moments when I'm in the clinic and I'm like, why is that lateral incisor mesial just tucked in, just a little lingual? Then I go back and I look at my simulation. Well, sure enough, I decided that I, as the doctor, was going to center this bracket, and it didn't matter what the simulation looked like of the final result. But in the final result, there's my lateral
Yeah.
rotated to the lingual on the mesial, and I was like, no, I know better. I know what my bracket placement should be. I don't think the simulation is telling me the truth. It was.
No, that happens. I mean, it's always interesting when you go back and look at setups and cases that you treated. You're like, how did I miss that? Or why did I do that? Right. And in those aligner situations you talked about, I think those are always challenging for a clinician because now you're not just managing the case. You're frustrated. The patient's probably frustrated. If it's a child, mom and dad might be a little frustrated. So you're managing all of that, right? But
Mhm.
at some point, we talked about how you made this decision to go in and open your own practice from scratch
Sure.
along the journey that you had. And was it at that point, it sounds like at that point you were pretty much committed to doing a lot of things digital. You mentioned, going paperless,
Mhm.
3D printing, IDB, was obviously on your radar. You wanted to beta test things. Um, what percentage of your practice now would you say is digital from a clinical standpoint, meaning aligners and indirect bonding?
100% of my Houston practice is digital.
Okay.
My Lake Jackson practice, which I acquired, it'll be 3 years in March, so it's like 2.5 years. The only reason it's not 100% digital is I'm still trying to finish some of the cases where the brackets were hand placed.
Mhm.
And now I have had cases that I have indirect bonded when I came in that are finishing prior to the cases that were hand placed 1 or 2 months
Oh,
before.
wow.
So, yesterday I called a debond. I didn't even realize it. The girls, I was like, just schedule it anytime December, January that works, around your holiday schedule. And my assistant comes back to my office like 10 minutes later. She goes, Dr. Cooper, she got those braces on in February. And I was like, yeah, wait, February? So like I'm counting, I'm like March, April, May, June, July, August, September. Okay. So she used in braces 8 months.
Yeah.
8 months. And it looks great. And I just was like, the case is ready. And I didn't skip steps. I went through all my night ties. She's in bendable TMAs. I made bends. Like, it's not like we skip steps here.
Right.
And she has a beautiful finish. And that just happens now. And so, you know, assistants that have worked in other offices or even worked in the office that I acquired and then get here, some of them are like, almost can't believe that it's actually done. And I'm like, no, it's really done.
Yeah.
So I'm like, do you see anything you would change if you were the kid's mom? Is the question I've started asking them when they come to me and they can't believe it's changed. I'm like, okay, so what would you change? If you were this kid's mom, what would you tell me to change at the next appointment? And they're like, well, nothing. I'm like, yeah. So that's why we're going to get them off,
That's awesome. Yeah.
So,
Nothing wrong with exceeding expectations once in a while.
right.
Just out of curiosity, obviously you have a certain percentage of phase 1 cases.
Mhm.
Are those digital for you too, or do you
I do.
direct bond? Oh, you
I
do?
do because the teeth are usually erupting and it's harder, I think, sometimes to get them just right. And when you're working on that 6 to 9-year-old range, especially when it's that mother's first child, they want everything perfect. And what I found is when I hand placed, because I don't like to go into full size wires on phase 1s because I don't want to put torque on the teeth because there's still canines inside the bone and da da da. There's different philosophies on this. So I'm not saying it's right or wrong. But that's my preference, is to stay in round wires. And because of that, I don't get full expression of the brackets. So then if I'm trying to bend wire in like a round steel wire, I it's just not as predictable for me. So I also put brackets on the baby teeth that I want to for comfort. And it just all goes on. It's not extra treatment time. Um, and I have found that sometimes I want to go all the way back to the sixes, but sometimes I don't run my wire all the way back to the sixes because I can put brackets on other teeth for very minimal cost. If you're going to go digital, to me, the bracket cost becomes, well, I'll talk about this. I find the most functioning, but also the least expensive bracket that I can, and I place it as close to perfect as I can. And my case finishes are much better that way than using an expensive bracket with them not digitally placed. And so if you have that philosophy, which I do, placing an extra bracket or two is negligible cost compared to anything else. And you might as well do it for the patient comfort.
Yeah. No. And I have to apologize. I almost kind of chuckled out loud a second ago as I was thinking about the lens that you just said you looked through in the patient's mouth. Is like, if I was this patient's mom, like, what would I change? And I was laughing because if the lens was, this is a boy patient, what would dad say? We'd be like, close enough. Looks good, right? So I like the fact that you raised the bar. Because I have a son and a daughter. My son, I'd be like, good enough. My daughter, I'd probably have a little higher lens to look through. That may or may not be fair, but I think my wife would have the highest bar, probably for both kids. But I like that you set that bar at the highest possible level. What would mom think of our daughter's smile at this point? Let's talk a little bit about efficiencies, or give me your perspective on this, because I think as a company, and a lot of companies do this, right? We come out with this new product and it's going to be so much more efficient for you, the doctor, and it's going to save you this many appointments, which is going to save you this much money and make you that much more profitable, right? Maybe talk a little bit about your perspective on some of those value propositions. Like, have you realized those? Or are you still trying? And are there any other things that maybe we should be talking about with some of these systems? Because that's what they are, besides ROI.
Yeah. Well, and I heard one, I can't even remember who said this. So whoever said this, whenever you listen to this, take credit. Because it's not original from me. They were like, well, if you listen to one company and they reduce treatments by 30%, and then you take the digital monitoring and they reduce appointments by 40%, and then, you decide that you're also going to use these fancy new biological wires and they reduce it by 20%, you're at minus 20% appointments,
Yeah.
And so it is kind of a funny joke, right? Because you have to balance that ROI on time in the chair versus your clinical result. And obviously you can't treat in negative time. So I think we're all looking at chair time, and I'm always learning about different ways to look at the chair time. Because I would challenge us as orthodontists who mostly are open Monday through Thursday. And I know there are some people that are open like on Saturdays or things like that. But like, you have one orthodontist working, you're mostly working 4 to 5 days a week, probably from 8-ish to 5-ish. You might work a little more extended hours and take a more extended lunch. Our efficiency for our rent is not that great, right? Like, our chair time utilization as a profession is not amazing when you compare it to a chair time utilization in like a hospital or an ER room or something like that. And so when we're talking about this, I think we're trying to maximize our time in the clinic, right? And I think we have to be careful because the patient, I don't think they care what our chair time utilization is, right? I think they care about the result they get. Can they walk out of our office and smile confidently? Did they have a good experience and have a little fun while they did it, right?
Sure.
Um, and so now when I'm looking at efficiencies, I also look at the convenience for the patient, right? Like, is this convenient for the patient or is it not? Um, and I like that's how I make a lot of decisions is through the lens of will the patient see the value in it? Because if we're just saying I as the doctor get to reduce blah blah blah, like is is that really what we want to tell our team that then somehow gets translated to the patient of like you need to use this so the doctor gets to be like leave at 3:30,
Right.
right? Like that's not it.
No.
So, efficiencies also are about how much time the patient has to spend in the chair in uncomfortable positions, right? Like when you're thinking about bondings and you're thinking about the cheek retractor and you're thinking about the NOLA, and we can all agree there's no perfect cheek retractor that our patients love, right? And we can all agree there's no perfect cheek retractor that allows us to perfectly view every tooth in the view that we need to get the perfect bracket placement. Um, Every patient has saliva. Every patient is wiggles, right? Like, especially when you're working on the younger
Yeah.
patients. And so, if we can reduce the patient's discomfort while they're going through procedures with us, that is a huge goal of mine. And that's something that indirect bonding has really brought as an advantage as I've looked at it over the years. And one of the reasons I've truly looked for using indirect bonding is my patient's comfort. They spend less time in those cheek retractors. Then on top of that, the efficiency in the case treatment. I talked about that patient that finished in 8 months. Well, I can tell you that I had maybe one or two patients that finished like that when I hand placed brackets. And normally they were pretty easy cases, right? Um, the doctor themselves, when they're placing the brackets, you put the same doctor in the chair in a clinic in real time, placing brackets directly. And you take that same doctor and you put them in front of a computer screen where they can turn the model around in any direction. They can stop and start if they need to. They can be like, oh, wait, this is a deep bite. I should move my anterior brackets up another half millimeter. And oh, wait, that makes the canines look funky. So maybe I should modify that. You can't see those things when you're in the mouth placing the brackets. And so I think we need to look at the indirect bonding as a way to make us as doctors place brackets in an environment where we can be optimized, right? As a person. It's not about one doctor can't place it direct and the other doctor can place it direct and there's a difference in clinical ability. I think you see a huge jump in the better bracket placement between the same doctor, whether one's in the chair dealing with the saliva and the kid that's shaking their foot, or the mom that's trying to text about childcare while you're placing her brackets. There there are things that we have to deal with in the chair. Then and all that pressure, right? Like that's pressure on you as a doctor. And then you have three other chairs waiting on you. Well, if you do it digitally, I'm not one of those that wants to take my work home, but I'm saying I'm sitting in my office while my assistants are doing their work and I'm getting this done digitally. Those fives, sixes, and those sevens are going to be placed much better than if I'm in the chair trying to do that with a wonky cheek retractor setup.
Yeah. No, that's a great point. So what I'm hearing is there are certainly some efficiencies that could contribute to less chair time. But maybe there's another part of the equation that I should be talking about if I go and speak to a doctor about IDB or aligners, in that there's some controls in there that are benefits to the doctor and the patient, whether that's from a cost or an experience standpoint. Forever growing up, I thought double fish hooks was the best cheek retractor available because that's what my brother did to me all the time. And I didn't learn about plastic cheek retractors until much later. So that was like a new invention to me. But yeah, I think maybe as companies out there that speak about efficiencies, maybe we're not speaking about everything in the way that we should be. We just tend to focus on the monetary side. So
Yeah, it's what we hear as doctors from companies a lot is number of appointments. And then if you can reduce the number of appointments, then you can reduce the amount of overhead that you have. And this focus on the reduction of appointments, although that does help your patient be more convenient, sometimes I think it makes the patient feel like they're not cared for. And so I think
Right.
that's why we shouldn't focus on that
Yeah.
as a community, right?
Yeah, good point. I have one more question for you, and we're going to wrap up this episode. Similar to the last question I asked you in our last episode,
Okay.
but slightly different. So, what would current you like to ask future you? If you
Okay.
could ask for one pearl from future you, what would that be?
Ooh. What are the steps that I need so that I can have 9 clinics? That's what I want
All
right
right.
now.
We're going to check back with future you and see how many clinics you have in another episode. But for today, I want to thank you again for taking the time, as always, and just the honest insights that you gave us in this discussion today. So thank you again, Dr. Cooper, and we look forward to speaking with you again in the future.
All right. Thanks, Trey.